and Dr. Ryan Westergaard, Chief Medical Officer in the Bureau of Communicable Diseases, here to answer them. We only have a half an hour, so we want to get right to it. When we call on you, we ask you to please limit yourself to just one question so we can try to get to everyone. And we begin right now with Denise Lockwood. Denise, are you on the call? All right. *6 will mute and unmute you. We will try to get back to her, but let's move on to Rob Sussman. Rob Sussman.
Hi, thanks for taking my question. Dr. Westergaard, this recent uptick in cases, I mean, is this, what strain of the virus is this first and foremost? And is this anything anybody really needs to be worrying about particularly?
Yeah, good question. So we're seeing, I would describe as, mild to moderate increases in case activity level. Our 7-day average of new cases is just over 1,000. And that compares in the context of where we were in January with the Omicron spike. It's only it's about 9 or 10 times lower. So it is compared to what we were experiencing in January. It's not as high activity, so the risk of becoming infected is not as high just being out in general community settings. But it's higher than it was several weeks ago. And the reason for this is probably several things. The variant that is spreading in this country right now is predominantly the BA2 subvariant of Omicron. And what was observed with that subvariant in Europe several months ago was that it seemed to outcompete or be transmitted quicker in communities than the original Omicron, which was by far the most highly infectious variant that we've seen. So it took a bit longer for this BA2 variant to take hold in North America, but it's here now. And the thinking is that's why we're seeing an uptick. Why it happened later compared to Northern Western Europe that we saw several months ago isn't really clear. Part of some of the factors might be that it's springtime and spring break and there's more gatherings going on. It also may be that we had so much activity level in January that the whole population has a level of immunity that is now starting to wear off, as we know that does after 4 to 5 months. So they're potentially pretty several explanations. As for whether people should worry about it, I would never say, to stop thinking or caring about COVID-19 because it can still be a very dangerous virus. It can cause severe disease, particularly in elderly, vulnerable populations and those who are unvaccinated. So we need to continue to track it, but our focus has shifted to trying to prevent severe disease, making people aware of therapeutics, which can prevent people from needing to go into the hospital, and just having general awareness that prevention strategies like wearing masks in indoor settings when disease activities get high are still things to think about. So it's we're in a better place overall, but a lot of the lessons that we've learned and the measures that we've taken over the past 2 years are still relevant, and we want people to still think about them.
Thank you for that. Let's go now to Caroline Bach, WKOW. Caroline. Caroline at WKOW. All right. What about Scott Bauer, Associated Press? Scott Bauer. David Wahlberg.
Okay, thank you. Dr. Westergaard, you talked about the BA2. The CDC data today shows that the BA2 subvariant of 12.1 is now about 29% of new cases nationally compared to 68% of BA2. What are we seeing in Wisconsin, and what do you think this new subvariant might do to transmission?
Good questions. We don't know that the new subvariant is different in terms of transmission. I think it's too early to know. I don't have the precise numbers of what the proportion of the newer variant is. Our dashboard is on the state lab is pretty specific, but the caveat is that there's a bit of a lag between when the sequence data get uploaded to that dashboard, and also the ongoing caveat that we're sampling a relatively small proportion of the overall cases that get transferred to the labs and have that whole genome sequencing. So I think it's fair to say that what is circulating in the United States is a good indicator of what's circulating in our region and in our state, particularly because we don't have good reason to think that it behaves differently, not meaning it doesn't cause more severe disease, doesn't cause a increased transmission risk. They're all remain very highly contagious. So because because we don't think it's substantively different, the precise proportions aren't probably as important. But I think the general trend that we're seeing uptake in all areas of the country, a little bit more in the Northeast, which often has been something that precedes what we've seen here, is an indicator that we may still see some additional increased activities in the months ahead. We don't know how high it's going to get, how long it's going to take, but we are in a bit of an upswing.
Thank you for that. Let's go now to Brian at WLUK in Green Bay. WLUK.
Yes, thank you guys for taking the time. My question is for Dr. Westergaard. Doctor, we often hear when it comes to treatment, the word milestone being thrown out. And now just yesterday, the first treatment was approved for children that are younger than 12 with remdesivir. So my question is, would you consider this a milestone, and why or why not?
The specific milestone of remdesivir approval for children, or just general therapeutics? You can clarify your question.
That's from again.
Yeah, just for children.
For children. Yeah, I think it's an accomplishment. I think it's fair to call it a milestone anytime that we have new resources available, new treatments available. So I think it's significant. Children are not becoming infected and hospitalized as in high numbers as they have in the past, and remdesivir is generally medication used intravenously for people in the hospital. So I don't think it's going to have a huge impact, but it's good to have those treatment options. The question, I think, gives a good opportunity to emphasize another point about therapeutics in general, which is that a big accomplishment, if you want to call it, or a milestone, is that we have a large quantity of antiviral drugs that can be taken orally in the outpatient setting that can prevent people from needing hospitalization. And they are approved for adults. They are prioritized for people who have risk factors that would make them more likely to require hospitalization, so older people and people with medical conditions. And the news from the field, from our healthcare settings, is that there's not as many of these drugs being used as could be used. So it's important to share this news that some people presume that because they're new, they're in short supply. The new treatments, molnupiravir and Paxlobit, are available in many pharmacies around Wisconsin, and providers can prescribe them to people who they feel that are high risk. So that is something that probably doesn't get enough attention. We're trying to make sure that all healthcare professionals are aware of this and try to remedy that misconception that they aren't widely available, because the supply has gotten much better.
Thank you for that. And before we go to the next question, we will ask you all to mute yourselves if you're not asking a question. And a reminder, *6 will help mute and unmute when you want to ask that question. Let's go now to Tiffany Olson, News 8 in La Crosse. Tiffany. News 8 in La Crosse. All right, how about Dan Klaus, KQDS? Dan, KQDS. Logan, WISC in Madison. WISC, Madison.
You're watching Action 2 News at 4:30 with Chris Roth.
Sean Kirkby, Wisconsin Health News. Are you on the call? Sean Kirkby.
Thank you. The CDC today released a report showing about 60% of the US population has antibodies for COVID-19. I was just wondering if that, if you think that holds true for Wisconsin, or if you had any kind of Wisconsin specific data on how many folks have been infected. Thanks.
Sure, I saw that report as well. It seems in line with what we expect here. Some of the data that go into that estimate are broken down by state, and we don't have them. I don't have them.
All right, thanks. We'll see you in just a few minutes. Well, rural communities across Wisconsin are seeing a rise in substance use and addiction, and in an effort to bring some much-needed help, Wisconsin Hospital Association, UW School of Medicine and Public
Three
Health.
brilliant minutes, sponsored by the brilliant attorneys at Jensen Law Firm.
Morgan Killing.
I apologize, Dr. Westergaard.
Oh, that's okay.
Do you want to try again, and we'll try to?
Sure,
we'll
sure.
try
Looks like she's still not muted, but.
Yeah, Elizabeth, you should be able to mute.
Yeah, we're just
we're
trying to find her in our list.
All right, done.
Thank
Okay,
you.
so what was the question? Oh, does the 60% antibody positive prevalence rate likely hold true for Wisconsin? I was saying it likely does. I think the entire country, particularly during the Omicron wave, had massive levels of infection, and 60% may well underestimate it, because we know many people who have mild infection don't make antibodies, and antibody positivity can wane over time. So the total number of people who have at some point had COVID-19 might even be higher than that. At times, we do have specific Wisconsin data from the labs that come here. I don't have that handy, but if you'd like to follow up by email, we could put you in touch with any specific estimates that we have. But 60% sounds very plausible.
Thank you for that. Let's go now to John Neisser, NBC 26 in Green Bay. John.
All right, thanks for taking my question. Dr. Westergaard, looking at the trends, and I know there are many factors that can go into this, and you can address that as you'd like, but how would you forecast where we're headed in this pandemic, or moving towards endemic at this stage?
So two questions. Where do we think we're headed, and what's the sort of the new normal? Or you talked about are we at endemic? I think it's really difficult to predict, and if anyone says they have a good estimate of where this new peak, when and where, how high this new peak will peak, I would be skeptical, because it's been very difficult to know what we're in for in the months or weeks ahead. So far, in comparison to what we saw during the first several weeks of the Omicron surge, that happened very fast and very rapid. And we saw from around the world that it was going up very quickly. So we expected that. This current moment, we're seeing moderate increases. Like I said, only about 10% of what the peak was during Omicron. And we don't have the signal from elsewhere in the world that there's something fundamentally new or different going on. So I think if we had to guess, we would say it may get higher, but it will, unless the virus changes dramatically, a Omicron-like surge where we see hospitals being full and disruption on that scale seems unlikely. So the second question about, are we endemic? What most epidemiologists mean when they say endemic is that a disease is present in a population or some defined geographic area indefinitely with a pattern that can be described as steady state or predictable. So COVID-19 currently meets the half of that definition, in that it's here indefinitely. It's not going away. It's going to circulate in humans and in animal reservoirs probably forever. But that second part, I think it's still too early to say that we know that it's going to follow a predictable pattern. For example, influenza and other seasonal viruses are pretty predictably have a peak in the winter and go away. I don't think we can say for certain that COVID-19 is going to do that or only that. The pandemic may be more sporadic. We may have large spikes intermittently. We may have years between large spikes as the virus changes. Even now, 2+ years into this, I think there's still surprises, and we don't know what the future is going to look like. So I think what do we take from that? Our lesson is that we need to be vigilant. We need to use the new technologies to do surveillance to see what the virus is doing and how it's evolving. And we need to prepare for the possibility that we'll see larger surges in the future. So we're trying to get our country, our state, our healthcare systems back to normal. But we've also learned a lot about the importance of planning ahead and knowing in what way will we have to surge our resources in the event that the disease surges again. And I think we've learned a lot about the importance of that and how to do it. And so those discussions are ongoing of how do we prepare for what's next.
Thank you for that. Let's get the next question to Katie, WXPR in Rhinelander. Katie at WXPR.
Yeah. Dr. Wester, you kind of just touched on this, but a little bit more of if you have a sense of what this surge or wave will do with hospitalizations. I know we haven't really seen an impact on them yet, but if you've got anything that can look at what you might expect in that regard.
Yeah. Well, we don't have a signal that hospitals are on the rise. Our 7-day average has been pretty flat. If you look at the Wisconsin Hospital Association dashboard, the numbers of hospitalized people right now, I think, are in the 150 to 180 range these past few days. So again, that's a little higher day to day than it was a couple of weeks ago, but very small in comparison to the peak in February or January, where we were over 2,000 people in the hospital at any given moment. So I think we have reason for optimism that the risk for severe disease on a large scale is lower than it's ever been. We have more people vaccinated than we've ever had. An even larger percentage of the population have had either some combination of immunity from prior infection or vaccination. The word about the importance of booster doses is getting out. We have more therapeutic options that can keep people out of the hospital than we had before, as I mentioned before. And once people are in the hospital, we've learned a lot about how to manage COVID-19. So I think all of those things are, number one, we have a lot to be grateful for. We've accomplished a lot as a community, as a profession, and as a overall health system. And I think that puts us in a good position that as we see more cases in the community, hopefully that piece of the pie that results in hospitalization will stay small. But it's important to know that there are individuals who are highly vulnerable, and it's useful for all of us to consider that we have some responsibility to protect others. So that means if we are feeling sick, we're going to go to a place where there are vulnerable people who are elderly, who are on immune suppressing medications, who are unvaccinated, or have other reasons to suspect that they may be likely to have severe COVID-19. We have a responsibility to stay home when we're sick. Wear a mask if you're unsure, if you've been exposed to someone. So those are the other reasons that the types of behaviors and attitudes that we hope catch on, that we've learned through the pandemic, is that we can keep each other safe by doing things that we took for granted before, like getting a test if you develop symptoms, wearing a mask if you have mild symptoms, staying home, following the isolation recommendations. So all of those things we hope will change our trajectory to not see large numbers of hospitalizations going in lockstep with increases in cases.
Thank you for that. Let's go now to Daniel Malloy, Spectrum News 1. Spectrum News 1.
Hi, Dr. Westergaard. Thanks for taking all of our questions here. You'd mentioned the surveillance element of this part a couple questions ago. I was wondering if you could expand on that just a little bit. I imagine it's changed over the last year, especially with the availability of at-home testing. Could you just kind of explain kind of how that's changed and, kind of the communication involved in getting the most accurate picture of kind of disease activity around the state?
Yeah, thanks. I'm happy to defer to Tracy as well to talk about some of our data systems. But I guess I'll start just generally speaking. There's a couple different kinds or flavors of surveillance. The biggest piece, as it has been all along, has been cases of COVID-19. When tests are positive, they get reported. There, laboratories and healthcare organizations that do testing are required to report those to the state and to the country. So we see that's where our curves come from. Cases go up, cases go down. As in addition to that, we do what's called genomic surveillance, or we have some system in place to take a subset of the positive tests, the sample that's left over after the swab and the solution goes to the lab, and see if there are what variants are circulating and if there's a new variant circulating. That we do in a smaller subset, but it gives us information about what variants are spreading and how that might affect the transmission. Then the newest part of this, which has been interesting to watch this science develop just in front of our eyes, is environmental surveillance, testing wastewater. And Wisconsin is one of the states that has done a lot of this and has developed a lot of technology and infrastructure to do this. So we have this on our dashboard as well. We can see the concentration, how much virus is being detected in wastewater treatment facilities around the state. So we look at it from different lenses, different perspectives, and right now they're all telling us about the same thing, that we're seeing an uptick in cases in most areas. Anything you'd add to that, Tracy? Yeah.
No, that was great. Thanks, Ryan.
Yeah.
Thank you both for that. Let's go now to WXOW in La Crosse. WXOW. All right, what about FOX6 Milwaukee? FOX6 Milwaukee, are you on the call? TMJ4 Milwaukee. TMJ4. WBAY Green Bay. BAY, are you on the call? Remember, *6 will mute and unmute your phone. All right, Adam at WisPolitics. Adam at WisPolitics. WISN. WISN Milwaukee.
Hello, this is Caroline with WISN 12 News Milwaukee. Dr. Westergaard, can you talk about Paxlobit as a treatment option? The demand is extremely low right now, but it's being prescribed as a drug that can help treat COVID, particularly for high-risk patients. What's your take on why the demand is so low right now for Paxlobit, and how is that looking here in Wisconsin?
Sure, I'm happy to talk about that. Paxlobit is one of the two oral medications, meaning the pill medications, that have been authorized under emergency use for treatment of people who are test positive and have risk factors for severe disease. The other is molnupiravir. Comparatively, Paxlobit seems to be much more effective. The early studies showed that it reduced the risk of hospitalization and death by 90%. So there's good reason to think that it's a valuable and important tool to have to keep people out of the hospital. I don't have the precise data, but I think your characterization is correct, that the demand is relatively low, that it's not being utilized as frequently as it could be. As for why that is, I mentioned one before, which is when they were first available and became distributed to states and then to pharmacies, the message that came out from the federal government and from us was that it's available in a very limited supply. And so it may be that a lot of providers took a wait and see approach, didn't incorporate it into their practice, didn't develop systems to refer people or to offer it to people on a routine basis. And that's something we've learned from our pharmacy colleagues, is that it takes some time to develop the systems and the electronic medical records, develop the pathways to get people Paxlobit, or to make sure that anyone who tests positive, there's a flag, you should think about Paxlobit. So some of those things that influence how we practice medicine in other ways just take some time to set up, and we're hopeful that as time goes on, it will become a more routine part of care. The other thing that should be said about Paxlobit is that it has some complicating factors that might make it make some prescribers hesitant. And specifically, it has a lot of drug interactions. So before prescribing it to someone, particularly someone who has a lot of other medical problems and is on other medications, other prescription medications, it's important to either consult with a pharmacist or use a resource to look up to make sure that none of the medicines that the patient is currently taking can interact in an unpredictable way or dangerous way with Paxlobit. So that's something that doesn't apply to in the same way to all prescription medications. So it takes a little bit of extra education, a little bit of awareness, and that may be something that makes it another barrier for it to be widely adopted in practice. But like all things, the field will catch up, and we're hopeful that'll become a more routine part of care as it becomes more commonplace.
Thank you for that. Let's try Mason Dowling, WAOW in Wausau.
Hi, yes, thanks for taking this call. I know we're short on time, so the main thing I wanted to ask is, do we know roughly what parts of the state are seeing this uptake of cases?
Tracy, do you have up to date? I think it's generalized.
Yeah, I was just going to direct you to take a look, particularly on the summary data page on our DHS website or on the CDC page. We do have the CDC community levels, and that's really what we're having people refer to as sort of the source of information to assess the risk level in your community. And there are a couple of jurisdictions now in the state of Wisconsin, Dane County and Barron and Rusk County, which have moved from the low to the medium level. But we are seeing, general increases in cases, as Ryan said, mild to moderate increases sort of across the state. But do want to highlight that there are a few counties that have moved from the low to medium community level.
Thank you for that. And our final question, Eric Gunn, Wisconsin Examiner. Eric Gunn.
Thank you. Either of you, who now is perhaps especially vulnerable? And has that changed at all over the course of the pandemic in that respect?
So the simplest answer is unvaccinated people remain particularly vulnerable. And we know that vaccination and boosters reduce the risk of severe disease and hospitalization, even among people who have previously tested positive. And so we recommend vaccines and now boosters for everyone who's eligible. Everyone over 12 is eligible for a booster. People over 50 are now eligible for 2 boosters, and that's a recent change. So people should be familiar with those recommendations and know that if they're not up to date, go out and get up to date, because I think that's still, that is the biggest contributing factor to lives that we've saved during the pandemic has been vaccinations, and being not fully up to date on vaccines is still the greatest risk factor for getting severely sick.
Thank you for that. Thank you, Dr. Westergaard. Thank you to Tracy DeSalvo. Thank you to all of you for participating. We do need to wrap up the call, and we know we did not get to everyone. So if you have additional questions or you need more information, please reach out to DHS Media at dhs.wisconsin.gov. Have a good afternoon.